the bloody side of regeneration. That's a fascinating topic. And this fascination goes back to the roots of our culture, because humans realized soon that without blood, you get weaker, you can die, and so blood was recognized immediately like a living force, but a mysterious living force, because they believed that blood carried the characteristics of the person, mental, physical. And this belief led to pretty extreme consequences. 2,000 years ago, Plinius the Elder reported that spectators were rushing down the arena to drink the blood of dying gladiators to gain their strength. And this became such a problem that they had to officially prohibit the practice. But still, fascination for blood properties remained through history, with some pretty bloody turns. For example, 16th century, we have the most prolific serial killer of all times. He was a Hungarian noblewoman who killed 650 young women to bath in their blood and retain their youth. I would say that was a really committed believer in the bloody side of regeneration. But at that time, there were also other believers, physicians. Physicians started to believe they could transfuse blood, but they had one problem, because at that time, blood was considered impure. Impure because of passion and human vice. And so they had an idea, and they say, well, a much better idea. We use animal blood. And as you can imagine, they had some problems. At that time, they didn't know about the problem of incompatibility among species, among humans. And so they had deadly consequences. And the practice fell into disuse. Until modern medicine. With modern medicine, we understood much more about blood, and in the last century, countless lives have been saved thanks to transfusions. And in the last 20 years, researchers started to look back again, not just as transfusion for saving lives, but as using blood for the potential to regenerate. And the concept is simple. Blood is not just one component. You have red blood cells, you have white blood cells, leukocytes, and you have smaller particles, platelets. And the attention fell on these small particles, platelets. Why? Because platelets have a really interesting function. When there is a wound, when there is a bleeding, they go there and they stop the bleeding. But we are built in a smart way. If we have a bleeding, it means we also have a tissue damage. And so they go there, they stop the bleeding, and at the same time, they start healing. And how do they do that? They have alpha granules, they have growth factors, and they release growth factors and bioactive molecules. And so the idea was, okay, why don't we take these platelets, we concentrate them, and in this way, we concentrate growth factors and bioactive molecules, and so we can have the same mechanisms that in vivo can repair tissues. We use the same mechanism, but stronger. And that was the idea. And to obtain this concentrate of platelets, well, I can summarize. Nowadays, we have roughly 3 main approaches, 3 technologies. One is cell separators, the other one is special filters, and the third one, which is the one that reached the clinical practice, is a really fancy technology. And it's this one. No kidding. Plain and simple concept of the washing machine. You can use delicate cycles, you can use hard cycles, double cycles. The point is that blood has different components, and when you spin them, they distribute because they have different sizes and weights, and so you can have blood, but separated. And you can have, in the bottom part, red blood cells, in the intermediate part, you can have leukocytes and platelets, and in the upper part, you can have plasma and platelets. And so you can take the intermediate part and have what is called platelet-rich plasma, PRP. And you can choose. You can have it with pure platelets, so you go above, or if you want more platelets, you also go and take the part with leukocytes, and you have leukocyte-rich platelet-rich plasma. And both these procedures, they both arrived in the clinical practice more or less 20 years ago. And at that time, it was about oral maxillofacial surgery. Only after a few years, 15 years ago, it started to go gradually also in the musculoskeletal field for sports medicine. And it was at that time, more or less 15 years ago, that I started following this topic. But at that time, we were really just a few early users. It was not so fashionable until something happened. It was not a scientific event. It was another important event, a sport event. It was a Super Bowl. And what happened is that 2 weeks before of that Super Bowl, 2 athletes were treated with PRP. And then they won. And so you had journals with titles, PRP helps athletes go back and play and win the Super Bowl. And these titles jumped from journal to journal. PRP helps win the Super Bowl. Jumped louder and louder until every weekend warrior wanted to have the same treatment of the athletes that won the Super Bowl. I want the growth factors too. And it may seem strange now that we know more about it, but we were talking about growth factors. It was a powerful message, so powerful that at that time it was considered doping. Let me tell you, this has nothing to do with doping. It's not considered doping anymore. It doesn't enhance the performance. But that was the hype. And so every company started to produce its own centrifuge to produce PRP in a cheap way so that physician could give it to patient. And the use starts spreading. In the end, it was safe. It was just a small injection of an autologous concentrate. So really big hype, but where was the science at that time? Well, I show you here a small graph which represents what was the situation for one field, cartilage. It's one of the most commonly used field to study this kind of products. And if you can see, before the red line, before what happened 10 years ago, the columns represent papers. There were just a few anecdotal reports. And after the spread of the use, well, research had to catch up. And so we started having more and more papers to understand the if, when, how it worked. And so now, after 10 years, what's the clinical verdict about this treatment? Well, we have some experience, and here I report what's the overall understanding of the main applications of PRP. So let's see. Achilles tendon, no evidence right now that it helps. So no indication for now. Rotator cuff, controversial. Elbow tendinopathy, controversial. Patellar tendon, anterior cruciate ligament, muscle lesions, cartilage lesions, all controversial. And before I go more in detail in the chapter of osteoarthritis, I like to represent this that looks like a bloodbath in terms of clinical results for this kind of treatment. And I'm gonna show you graphically what's happening here. That's what's happening. And that's not the broken heart of a researcher that stopped beating for these results. That's a classic Gartner's hype cycle. It's something that works for every new product, and PRP has the same trend as well. So you have some early users, some modest expectations, and then something happens. Like, for example, you have famous athletes using it, and then you start having more expectation and hopes until you reach an inflated peak of expectations. But then, when you start using it so much, and sometimes wrongly, you have failures. And then you have disappointment, and you go to the disillusionment. And now we are here. And this may look pretty depressing, but let me tell you, it's not. That's really positive, because it's a health phase in the development of a technology. Because now we understand where it doesn't definitely work, then we don't do it anymore. We save money, energy, time. And we can use these resources to invest in the direction where it seems to work, so we can refine it and maybe reach a plateau of clinical utility that will never be as good as the hope that we had at the beginning, but still, maybe we can really have a weapon that works in our hands in the clinical practice to address diseases. And there is one area where PRP seems to find his space, and it is osteoarthritis, which is one of the most common and invalidating diseases. Although it's a bit counterintuitive, because at the beginning, when we were targeting osteoarthritis, we were thinking, we inject PRP, is going to help cartilage, but the rationale for using blood is that blood is in every vessel in the body, and so it helps every tissue. But it is in every tissue but one, cartilage. So why does it work? And what we learned then is that actually, when you inject a joint, the target is not just cartilage, it's meniscus, it's the synovial membrane, so it's an overall effect. And this overall effect gave us an improvement that we measured. This is one of the earliest graphs of the earliest publication in the field. And we noticed there was an improvement. But this improvement was lower and lower the more advanced osteoarthritis we addressed. So we learned pretty soon that it was not a treatment for everybody. And another thing we learned is that it improved, and then at 12 months started to decrease. And this was not what we expected for a regeneration effect. In this field, when you aim to regenerate cartilage, you usually have an improvement at 12 months, a bit more at 24, and then stable results. And this was different. This was a classic homeostatic curve. And this was a turning point. We learned that PRP wasn't just working for stimulating regeneration. It was also working through the modulation of the inflammation to homeostatic effects in the joint, which puts PRP in a niche where it fights with another product that is now in the clinical practice and commonly used, which is hyaluronic acid viscosupplementation. And we compared them. And we saw that they have similar results at the beginning, and then PRP seems to have a bit better results and longer results over time. So probably we found a place where PRP can be helpful in the clinical practice. But truly, well, the truth is that we were expecting a bit more. And so we started to try to see where we can work to improve it. And we look at the most controversial aspect. I told you, you can have PRP with or without leukocytes. And leukocytes are controversial because from one side there are researchers that say that with leukocytes you can have more growth factors. On the other side, others say, well, but you can have also more inflammation. So we went looking, and we started in vitro. And in vitro we looked at what happens putting the cells of our joint. And on the left you see cells are moving, they are feeling good. And then on the right you see we induce inflammation like in the joint. And you see cells, they are not moving anymore. They're like stranded on the couch after a strong hangover. They are there, they don't move. And so we try to help them. And we give PRP, with or without leukocytes. And we saw that both PRPs helped, but with leukocytes, there was a bit more of inflammation. So maybe, oh, that's it, we solved the problem? Well, it's different in vitro, where cells are naked on the plastic, than in vivo. In vivo, we have cells causing their own matrix in a complex environment. And so we went to look what happens in vivo. And we took synovial fluid before and 1 week after the injection of leukocyte-rich plasma from our patients. And we couldn't measure any increase in the inflammatory molecules, so we didn't find it. What's happening? Why these controversial, these contradictory findings? And we could answer with a further study, a clinical study, where we compare two groups, one treated with leukocyte-rich, one treated with leukocyte-poor PRP. And we saw an improvement and a trend that was overlapping, but with one difference. The group with leukocytes had some pain and swelling reaction in the first 2-3 days. So what we saw in vitro was true, but not so detrimental in vivo. And so we realized that it was not just a leukocyte matter, probably. And the truth is that now we know every PRP differs for so many variables, the type, amount of cells, but also the way you activate it, the presence of fibrin, the architecture of fibrin, and all these factors can influence the release of these growth factors and bioactive molecules. And so there is a lot of variability, heterogeneity. And that's why there is an attempt to classify, put order in the field. And it's not so easy. For example, if you take 200 patients that were treated in our trials, and you try to classify them with 3 devices. The first device gave us 2 categories, the second 3, the fourth device 4 categories with the same classification. Because the point is that blood is different from person to person. We are talking about a biological product. So this is pretty challenging. But something that is even more challenging is the attempt to standardize this biological product. And to show you why, I'm going to use a volunteer. I'm not going to tell you who he is for privacy issues, but let me tell you, he's a young, sport-active volunteer. Okay, relatively young and relatively fit, but definitely passionate about research. And in the last years, there were many experiments. And for example, we dosed one of the most commonly dosed growth factors, PDGF, in PRP. And we found in one experiment that there was a certain amount. And then 3 weeks after, we did another experiment. And 3 weeks after, another experiment. And 3 weeks after, another experiment. And we found 3 times difference. And then in another experimental setting, we produced 2 PRPs. So blood was taken 1 minute apart, and we already found 30% difference. And then we did same person, same device, same day, just 6 hours different, and we found 10 times difference. And what if the nurse chooses the left or the right arm? That's pretty random, right? And we found 5 times difference. So this is mainly a provocation. It's not a robust study, but to show you how difficult it is to standardize. And probably we need better technology, and maybe we'll never be able to fully standardize it. So difficult classification, difficult standardization, something where we can do something is the concentration concept. Because at the beginning, we were thinking we have a centrifuge that can concentrate 2, 3, 4 times. Well, this concept doesn't work really well because we start from different levels of platelets. Like I can have 400,000 and another healthy person 150,000. And then you have different devices with different concentration coefficient. And then you can have approaches where you inject 1 or 5 or 10 ml, and all these factors, putting them together, you can have 75 difference in terms of platelets that you inject. And you will never give to a patient 1 aspirin or 75 aspirin, right? So we have to understand how much we are giving of what we are giving. And so now we start talking about dose. For example, in our cases, we more or less gave 5 billion platelets. And this is a really big improvement in the field. And another improvement, well, the first papers were about, we treated 200, 300 knees, but now we know it's not just a knee with osteoarthritis. Different knees have different levels of osteoarthritis, and we can have earlier degrees, and they can answer, maybe more advanced phases where there is no viable tissue to respond to the stimulation, so it doesn't work. And these knees can have different clinical manifestations. They can have swollen status or a painful dry knee. And these knees, they belong to completely different patients, an athlete, or it can be a middle-aged patient with microtrauma, middle-aged woman, a senior man, or a senior woman, or someone with a metabolic disease. And we are starting to study all of them to understand better how to improve the field. So we did a lot of improvements, and all with this technology. But here's the good news. Now we have much better washing machines. Technologies are improving in every field, and the better news is that technologies are getting affordable, smaller, cheaper, and we will have them soon available at the bed of the patient to choose the kind of cells you use, to choose what you give to your patient and target the disease. And in the future, we can even filter with receptors the growth factors and have the right PRP for the right patient. So we came a long way, and we had some shadows, we had failures, but we have also light, because we still have a long way ahead, but we know where to go. And we're going to have soon next PRP generations to help us in exploiting better and more the potential of the bloody side of regeneration. Thank you.